I'm Marianne Pearson, the Senior Director of Patient Navigation and Family Support at the Colorectal Cancer Alliance. CRCtalks is a new Alliance program to amplify critical conversations that happen between providers and patients to benefit everyone. We will hold a CRC talks every 2 months going forward on various topics from treatment to survivorship, plus screening and all the topics in between. Watch for the Alliance's social media channels and email newsletters for more updates. Today marks a premiere CRC Talks, and we're so glad you all can join us. This afternoon's program is brought to you by our generous corporate supporters, Genentech and Natera. Before we get started, though, we'd like to share a short message from Natera.
Signatera is a personalized tumor-informed blood test that can identify molecular residual disease or recurrent cancer sooner than existing methods by detecting the presence of ctDNA with high sensitivity and specificity. Physicians can use Signatera to support more informed treatment decisions by determining risk of recurrence, detecting early recurrence, and assessing changes in ctDNA levels. Revolutionizing cancer care begins with revolutionary testing. Learn more at nateraoncology.com.
Thank you again, Natera and Genentech, for your support. A few housekeeping items before we begin. We will be reserving some time at the end of the program to answer questions you can ask. You can ask your questions by clicking the Q&A button at the bottom of the screen. We'll get to as many questions as possible, so please do that. Following this talk, you will be directed to a short 1-minute survey, and we'd greatly appreciate your participation. Finally, to watch this video later, you'll soon find it on bluehq.org, the Alliance's online patient support hub. Now I have the great pleasure of introducing today's speaker, Dr. Jennifer Klemp. She's a professor of medicine in the Division of Medical Oncology and the Director of Cancer Survivorship and the co-program leader for cancer prevention and control at the University of Kansas Cancer Center. Her clinical research practice focuses on cancer genetics and cancer survivorship. Dr. Klemp serves on a number of national boards and is a subject matter expert in cancer genetics and survivorship. Has peer-reviewed funding, including an NCI R01 focused on shared care between oncology and primary care of the cancer survivors. Her research interests also include a focus on technology to increase cancer genetic education and testing, along with a multidisciplinary approach to cancer and survivorship. Thank you so much for joining us today, Dr. Klemp.
Thank you so much, Marianne, and to the Colorectal Cancer Alliance, who are a great group of people. And I think the resources you have are second to none. So I'm so glad to be able to be part of this kickoff today.
Thank you.
And as we kind of jump in today, I do have some slides for us to kind of take us through some talking points. Some of the things that I think are going to be really important is kind of understanding some of the nomenclature, how we define certain terms, how some of the things, especially like the term precision medicine, will fit into kind of the life cycle of how we treat cancer, both actively treated or into the different phases of survivorship. And really what's important for us to know as we have shared decision making between our patients, our providers, our cancer centers, our advocacy and other supportive care groups. It's really a dynamic kind of environment we live in regards to cancer care, and it gets more confusing because there are all these moving pieces. So today, and the first of the CRC talks, I hope we can kind of set off the tone and provide you with some of those definitions. We'll start by talking about kind of that broad stroke of what is a cancer survivor, or who is a cancer survivor, how do we identify and prepare for some of the common or less common late effects of cancer treatment, and then how do we identify what are the greatest risks for the individual. We also want to understand the role of precision medicine, how that isn't just sort of a one-time a snapshot as part of a cancer care continuum or the cancer journey, and then leave some time for questions. And hopefully we'll be able to answer your questions. As Marianne said, I do have funding from the National Cancer Institute. I do work with several partners, and I also work with a large precision medicine company called Caris Life Sciences. Next slide. So I'd like to start by kind of talking through the definition of a cancer survivor, because I think that as patients are in a cancer care environment, whether it be an outpatient cancer center, a hospital setting, an academic medical center, it's going to look and feel a little bit different. And I think that sometimes when we talk about survivorship, I'll have patients come up to me and say, wow, like, how do I get this whole picture of what you just described as survivorship? So some of it may already be in the cancer care environment where you're either actively getting treatment or supporting someone getting treatment, but some of it we sort of have to kind of actively and proactively seek out. So we'll talk through a little bit of that. But the definition is anyone diagnosed with cancer from the time of diagnosis through the lifespan, and it also includes those individuals like family members or close friends who are part of, if you will, that patient's cancer care team, and helps make sure that they have the support they need, the rides they need, all those pieces that are integral in regards to the cancer journey. So I think it's really important that we think about from the time of diagnosis. And oftentimes when we think about survivorship, we think about it like once we're done with treatment. And a lot of our patients will say to us, I really don't like that term survivor. Like, I don't align with it. I don't really get it. But here's how I like to frame that. This term has been around for a long time, actually back into the late 70s, early 80s. And once a term sort of settles in, it's hard to change that. So I think the way I'd like you to think about it is it gives us an anchor of diagnosis through lifespan and helps us align with things we should be thinking about, late effects we should be thinking about. How do we get the care that we need that's comprehensive? And if we can just sort of put the term as, well, this is the term we have, and just sort of accept that, it's a lot easier, because I agree that maybe that's not the perfect term and it may not be one that you resonate with, but it's just meant to sort of give us a shared name or nomenclature so that we can provide the kind of multidisciplinary care that our patients and their families need. Next slide. I like this next slide because I think the visual is very helpful. It shows how, the incidence and the survival of a diagnosis of cancer has grown significantly since the mid 70s. I will tell you, this year I celebrated my 27th year at the University of Kansas Cancer Center. I would like to say I started there when I was 12, but I did not. But in that almost 30 years where I've been working in cancer care, there's been an enormous amount of change. And this silver tsunami, as it's called, really indicates that by these different colors. I think the first thing that you'll see is that cancer still is rare in individuals who are younger than age 50. So it is a disease that is more common as we get older, but this figure is going to tell us some key indicators. It's one reason why in younger individuals, especially younger than 50, we always kind of think about genetics as a first step. We also see that, especially between sort of the green, purple, and blue, if you can see those colors, or 65 to 85 plus, that's 2/3 of our cancer survivors. So that means that if people are over 65, that's a Medicare population. It's a population that usually has more than just cancer as a health issue or what we call a comorbid condition. And what we also see is patients living much longer with and through their cancer. So that term I also use a lot because it means that any individual from diagnosis through lifespan, whether they are still actively receiving treatment and have metastatic disease or will actually be cured of their cancer, all of those individuals require a chronic care model, or just like we would treat diabetes, or heart disease. That's how we want to frame cancer survivorship. It's something that for the rest of an individual's life, cancer will always be part of that healthcare discussion. And so this picture sort of highlights that, also highlights that we have a whole lot more patients living with and through their cancer, which is a real indication of the science, of the really the teamwork that everyone on this call, everyone we depend on in a cancer care environment, or in a pharmaceutical company or a diagnostic testing company, we all work together to really focus on the patient and help extend the quality and quantity of life of our patients. Next slide. This is a map that we built early in our program development at the University of Kansas Cancer Center. And it's really meant to take survivorship to the time of diagnosis and start thinking about the needs of our patients. You'll see that genetics is one of the first little bubbles right next to the survivorship sign, because genetics is a way that we define really the characteristics of the tumor, and it helps guide treatment decisions. It also will tell us if a patient potentially has an influence that they were born with for influencing the risk of developing that cancer. The second little bubble is like a navigation or a compass, because every single patient that is actively being treated, has gone through cancer treatment, or will continue to be treated, we constantly need navigation. This is something that doesn't stop just because our treatment stops, and sometimes gets a little bit more complicated because there's not as much support sort of as you go through this journey, or the map, as you can see here. And so it requires us to always touch base and think about, from the patient perspective, what is my role? What are the expectations and the roles I have of my cancer care team? How do I fill in those gaps? And how do I navigate this map? I think the important thing to think about is these bubbles are all purposeful. You want a treatment plan. You want to think about things like sexual health, fertility. You want to think about your heart, your brain, your bones. All those pieces are important, and they may not be the priority at the time of treatment planning, but they definitely are priorities as we continue through this survivor journey. The roundabouts are also very purposeful, because some of our patients will never leave the treatment phase of care. Some will leave and come back, and some will go on to continuity or longer term or extended survivorship, as it's called. And so there's the same needs, but in different ways at the different phases of the care journey. And I think it's important that we think about those from the vantage point of the survivor, because as you're thinking about your needs, do you have more than one health condition or comorbid condition? Do you have high blood pressure? Do you have arthritis? Are you still trying to work on, getting a more active lifestyle? Those are very important from the time of diagnosis, and they're also very important as we think about continuity of care. But what happens along this journey is that we may not have all the resources that we need. We may not know the questions to ask. And I think that's where partners like the Colorectal Cancer Alliance and using tools like Blue HQ will be very helpful, because you'll be able to pop in, get information, and really help kind of fill in those gaps and find those resources, or find the way to ask those questions. And I think that knowing what resources are out there and knowing how to use them can really help empower us to be more active cancer survivors. Next slide. So this is not meant to scare you about every potential late effect that could possibly happen on the right side of this picture. It is meant to say that we really do need to think about sort of a head to toe as we think about late and long-term effects. But those are influenced by the type of treatment that we would recommend. Are you getting one therapy? Or, as in many of our patients, they get multiple therapies. That can include surgery, radiation, chemotherapy, immunotherapy. So there's a lot of different pieces to the treatment puzzle. And then how do each of those impact potentially the common things that we would think about as late effects? Obviously, there's psychosocial issues like anxiety or depression. There's cardiotoxicity, or does it already impact maybe a pre-existing condition you have that's already causing some risk factors for heart disease or other heart-related conditions? Is there potential for bone loss or neuropathy, where you get tingling in the fingers and toes? So these side effects or late effects effects are really also meant for you to sort of take a baseline. Where are you today? And then you are the best gauge of how any of these late effects change. Now, what happens sometimes if we give a patient a kind of a checklist, sometimes patients will check every single one. And some of those are baseline, right? You already have maybe some arthritis, or maybe you have diabetes and you have neuropathy or that tingling already. Those are important features of your health status that your providers need to know about, because they can take that into account as they're managing your care, not only from the treatment planning, but sort of what are the next steps and how do we manage you, and maybe what other specialists or primary care are needed in that discussion. So as you can see, as we start layering these sort of issues or factors into the survivor, it's really difficult for us to figure out, well, what's the greatest risk as we think about this for the patient? At the beginning and at treatment planning, we want to take care of the cancer. We want to treat the cancer. We want to stop the cancer, slow down the cancer, whatever that goal of treatment is. But then at the same time, we don't want to decrease the quality and quantity of life because there's other factors that the treatment could impact, or some of those late effects. So I think the important part is that this is not a black and white kind of question. This is a very gray question. And as we talk about the role of a survivor in this conversation, it really is part of what we call in healthcare delivery, shared decision making, where you're going to be given a recommendation. Hopefully your provider and your care team are going to take into account all these factors, and then together you're going to make a decision. These are some of the hardest decisions that I think our patients and their families have to make. And we don't want patients to have decisional regret, or to think about, a year from now, wow, should I have chosen something different, or should I have done a different path? Choices make this more complex, but it's why we need to depend on our care team. We need to use all those resources that are available, and we need to get as informed as possible. And I'll show you some of the terms once again, and some of those factors that go into shared decision making, because I think it's gotten a little bit more clear in regards to using things like precision medicine, but also now we're having to learn a whole nother language in addition to just the cancer care language that was an issue 10 years ago. Now we have new languages that we're learning, so we're having to learn really quick and make big decisions in a pretty short period of time. So that's a lot of responsibility for the patient, and we want to be here to help support you. Next slide. So we talk about the term risk stratification, and this really goes into treatment planning as well as kind of any of the steps that will be taken as part of cancer survivorship. That includes being able to take those factors, put them into sort of an organized fashion so that we can determine, how we deliver not one size fits all care, but more personalized care based on those risk factors. Next slide. And the risk factors are identified through sort of the type of treatment, the type of cancer. Are we doing a needs assessment to really understand what those needs are? What are the common late and long-term effects based on the cancer type and the treatment, those comorbid or other health conditions, and then how we engage you, the survivor, so that we can help address those as you go along. And we're not sort of waiting till the end, and now we have like 5 issues that we could have hopefully addressed earlier on. So sometimes stockpiling those issues is not the way to handle it, but you also want to figure out, well, is it my oncologist that I talked to about this? Is it my primary care? And as you heard Marianne bring up, a lot of the research I focus on now through being in this field for so long is really, how do we engage primary care, and how do we make sure that your care team is able to understand their role and what your expectations are, so that you know who to go to for what types of issues. So we may use navigation, and we shouldn't may use it. We should all be using navigation of some way, shape, or form. And it doesn't mean you have to have an actual navigator doing that. It could be tools like Blue HQ. It could be that you actually have a navigator at your cancer care facility. It could be your oncology nurse or your physician who helps to navigate. So navigation is a term, and you need to think about it as all encompassing, because there's a lot of different pieces and people that will help navigate you along the journey. You may get kind of a plan, or you may get different documentation kind of helping to guide you. That's always nice, because it's sort of nice to have a to-do list. We've kind of converted ours at the University of Kansas Cancer Center to more of that sort of what we call like an order set or a to-do list, because that's really the way that the patient knows what they're supposed to do, the cancer care team knows, and then all those other providers or other individuals or groups also know, because role delineation, or who does what, is vitally important in your cancer care journey. We also need to have pathways. We can't say, well, we'd love for you to get some cancer rehab. Here you go. Here's a piece of paper that says you should have this. And you're like, what? Where do I go? Do they know what they're doing? Do they have cancer certification, so that if I've had a lot of lymph nodes removed, they know how to deal with that? You want to feel confident, and you shouldn't have to sort of find your way. These should be definite referrals that you want your providers to help you engage with, and help you secure those as well. We also need education, and you also need to know that from the provider side, you expect them to know everything about everything, and that's not always the case. They know a lot about the thing you want them to know a lot about, but when we think about cancer from that bigger picture, or the whole person, they may not be as a subject matter expert in the whole patient, and that's where we sometimes have to piece together the experts, the referrals, those specialists that you need to give you the complex care that you need and deserve. And technology, I will tell you, as resistant as some people are, if we don't incorporate technology, we're getting left behind. That's the way that providers communicate. Now, I will tell you, we still text message each other, because sometimes you just can't get a hold of somebody, and the electronic health record is a bear. But technology is a place where we have to get comfortable, because that's really the common way that we communicate, and that everything is tracked and translated. So technology is a love-hate relationship, I think, for most of us, but it's definitely only becoming more commonplace. So on the right side, all of these factors go into account so that we can help best risk stratify what are your healthcare needs. And they may be high, but you have great social support. You have a great team around you. Your family is supportive, your friends, your religious organization. Or you may have very low social support and you need more of that, but your health issues are moderate risk. So these are all important so that you get more of a personalized care approach. Next slide. And the next two slides are similar yet different. And this is the comprehensive view of survivorship care, meaning all of these bubbles are things that may impact your care both during treatment, post-treatment, or as you continue to get treatment. So it could be physical or more health-related conditions. It could be psychosocial. It could be health behaviors where we need to, instill lifestyle changes for diet, exercise. It could be a clinical trial. Maybe you're part of an underrepresented population where we need to really help and focus on access issues and inclusion issues. So as you can see, there's an awful lot of pieces that go into that puzzle. And the next slide shows the individuals who will help you achieve that. And so what this shows is it may be oncology or surgery, radiation oncology, primary care, specialists in urology or sexual health or GYN, cancer rehab, OT. So this village that it takes, you may say, well, I don't have all these people. Where do I get all these people? I'd love to have that. Or you may say, do I really need all these people? And that's where risk stratification comes in. Which of the health needs and the care needs on the previous slide match up to the provider needs? And then which ones do you actually need? So the important part is you want to also be able to opt into some of these, because you may say, well, it wasn't identified by my provider that I need, anything targeted with lifestyle, but I do have questions about my diet during treatment, or what about supplements and should I be taking those? Those are questions, and those are things your provider needs to know about, because some of those can obviously impact your treatment or how some of those treatments actually are broken down in your body. So you want to do the best things for your treatment experience, but who do you ask those questions to? And I often think it's good to obviously make a list list, know what those questions are, and then if there's a nurse who is kind of helps with intake, or you have a nurse navigator, it's always good to review that list and say, who should I address these questions with? Because our patients will often say, well, my doctor only has 12 minutes with me, so what do I focus on with my physician? And that's a very good way to handle that, is you want to risk stratify, if you will, your questions and your concerns, and then who's the best person to answer those. Because sometimes you're going to ask the wrong person, maybe get not the best answer, and it's not going to meet your expectation. So I think expectation management in cancer care is under talked about. We don't talk about it enough. We don't sort of address it enough. But if we can help you meet those expectations and help guide you through that navigation process, it really makes the whole journey a little bit easier to navigate. Next slide. So this is a very busy slide, and this is really trying to get to the overarching message that we don't do one size fits all treatment anymore. If you would have been treated, 15, 20 years ago, it was very much like, you have colon cancer, this is the treatment, there is no other option. But now that's really not how we do it. So as you can see the figure on the left, it was sort of like, here's the whole group of colon cancer patients. Here's how we treat them. If a patient has an adverse reaction, well, they just won't get that treatment, but we don't really have any other options. Today, this is shifted, and it's shifted to a real risk stratified treatment model, where we look at things like, okay, what's the cancer type, but then what are the biomarkers? And you probably hear this word biomarkers all the time. And we'll talk a little bit more about what those biomarkers are here in a second. But we also look at things that are individual to the patient, their demographics, their clinical features, and so forth. So the term biomarker is thrown around a lot, but basically there's going to be different ways that we look at characteristics of the tumor. There's different ways that we access those, like you heard in the video that kicked off this presentation today. And then those help us break patients into subpopulations or different biomarker populations, because we have what's called biomarker-directed therapy. They also are influenced by the second little gray bubble, which goes into the true definition of precision medicine. Precision medicine means using genetic and genomic information, but also environmental and lifestyle information. So it's sort of threefold: genetics, lifestyle, environment. And it's important to take that into account, because one of the biggest frustrations about biomarker testing, and let's say we're talking about KRAS, or you're talking about HER2. So you can have a indication off of your biomarker test that you would benefit potentially from a biomarker-directed therapy. But why don't all patients respond the same to a biomarker-directed therapy? And the reason for that is those other factors. No gene works in isolation. They work as part of sort of a chain reaction, and there's lots of interaction between our genes, our environment, and so forth. So when we think about biomarkers, if we ran every patient, if we started with 100 patients and we run every patient for a large genetic profiling test, we would probably find that anywhere between maybe 15 to 25% of patients, we would find on a good day, has a biomarker that we could identify off that large genetic test to tell us potentially which therapy a patient will respond to. But then you have a lot of patients in that bucket that we've now narrowed down to, say 15 to 20%, who maybe respond, but some will respond and then eventually stop responding, and some never respond. So why do we have sort of three different buckets from a population that the biomarker told us, well, this should be the right therapy for that patient? And that's because of all those different factors. And that's why sometimes with clinical trials, they're trying out another companion drug or therapy to the one that the biomarker tells us we should use. They're trying out different combinations or maybe sequences of those therapies. So this is much more complex. And I think many patients go into biomarker testing thinking, oh, they're going to find the magic bullet, and that magic bullet's going to tell me what I should have, and there you go. But it's definitely not that easy of a story. It tells us, as you can see in this last picture, kind of which bucket you potentially fall into. But you also need to remember that there are other aspects to this that influence how our biomarkers can predict what we will and won't respond to, and potentially, like you'll see on the next slide, the next two slides, kind of how we access that. So we have somatic mutations and we have germline mutations. Somatic are in the tumor. They happen because of wear and tear, because of genetic mutations that happen throughout our lifetime. Germline mutations you're born with. These are things that we can't get rid of. Wouldn't it be great if we could? But we're born with them. And for colorectal cancer in particular, Lynch syndrome is the syndrome that you may have heard about, and those are the genes associated. I will tell you that somatic and germline mutations influence each other. They're not always, you don't always have one and the other. You don't always have a somatic and a germline. Like if you find an MSH6 on a somatic test, it doesn't always mean you're going to have a germline MSH6, but they definitely influence each other. Next slide. And we collect these from different ways. The somatic can be done with tissue or blood. Stool is great for screening tests and sort of ongoing kind of screening type preventive tests. But we collect things from different places because we do different types of testing on them. So don't always be surprised if someone wants to have a sample from your blood or even your buccal, and that's the spit, because we do a lot of germline testing or that inherited testing from our buccal. Next slide. And this is just meant to show you that testing isn't always just done at the beginning. So yes, we should be doing biomarker testing on pretty much, I don't know of any patient we shouldn't be doing biomarker testing on. There's some examples of different biomarkers that you may have heard of, like KRAS, BRAF, MSI-high, HER2, PD-L1, and so forth. It helps us select the therapy, and then it helps us monitor our patients. And we may continue to do these tests throughout. Similar to, once again, the video you heard, this minimal residual disease will help us continue to identify higher risk populations that may continue to need therapy. Or it may tell you early when a therapy is maybe not working as well as we had hoped it would work. So testing across the continuum is very important, and important for you to know the role. Next slide. So this goes along and overlays with our map, which tells us about treatment. All testing is throughout this cancer journey, not just at the beginning. It helps us risk stratify what we should be doing based on those biomarkers and how we treat our patients and monitor our patients. So this map is a really good guide for us. Next slide. And so these are just sort of a little checklist that you can have sort of in your back pocket as you're thinking about what should happen at a treatment visit, or as you go into extended survivorship. What are the types of issues you should be looking at? What are the types of questions you should be asking about? And really, what is that comprehensive picture that will help you navigate towards some of the survivorship services that we highlighted earlier? Next slide. And so in summary, I think that, we've covered a lot today, kind of talking about the role of risk stratification and the complex issues of comorbid conditions and just the complexities of our survivors. There's an ongoing need to continue to stratify that risk and to help you co-manage the complexities with primary care and other specialists. And when we think about precision medicine, it's not just a one snapshot in time. It can be at the beginning and then throughout, a extended period of time, depending on if you're currently being treated, will continue to have treatment, or even if you're in a curative place in that continuity of care of survivorship. What is a potential role of testing down the road, and is there a role? So these are things where I think it's very important for you to sort of ask and set that expectation with your care team so that you understand the role of precision medicine and that you understand what those greatest risks are and how you put your puzzle pieces back together with you really being at the center. And I think that's a really important role for our cancer survivors. So I want to thank you guys for your time today, and I will turn it over to Marianne to see if we have any questions.
Thank you so much, Dr. Klemp. That was awesome. We do have a couple questions for you today. Let me get to them. The first one is, mental health is something that we can be exacerbated by a cancer diagnosis. In particular, as someone who's been in remission for about almost 20 years now, I sometimes feel crippled with survivor's guilt. How can we address mental health during treatment and also in remission stages?
Yes, that's a
Great question.
very good and loaded question. So I think the hard part about cancer is that there are things that we can expect, but there's those unexpected. And survivor guilt is one of those that it kind of pops up, or it pops up when you're talking to someone or you're supporting a friend. It'll pop up in different places. So I think during treatment, it's really important to think about, especially early into a diagnosis, are there other mental health issues that one has already dealt with, right? Do you have a history of depression or anxiety? Is there already any type of pre-existing stressors or mental health issues? That's a very good guide, because those are going to rear their head, especially when you're in such a stressful situation like a cancer diagnosis and treatment. The important part is that if your cancer care facility doesn't have mental health services, because as we know, they're not only rare in the community, they're sometimes even more rare when you start getting into like a cancer center or cancer care environment. There are online resources. And I think using Blue HQ and some of the navigation tools that you'll see and we'll leave you with, that's one place to start to help navigate you. But there's also additional resources that hopefully your cancer care team can highlight for you. I think a lot of people will give mixed messages about things like support groups. I always tell people it's sort of like a sampler. You don't know till you try it. So you need to sort of try it. And so when I run these like groups for our breast cancer survivors and other cancer survivors in regards to lifestyle. So we do breast, colon, and so forth. And when we do things, especially dealing with mindfulness, we'll do 5 different ways to sort of focus on mindfulness, which is really helpful during treatment. It helps you relax. It helps you kind of calm your brain and quiet your brain. But patients will be like, oh, well, I don't know how to do that. I don't want to do that. I don't like that. But I'm like, just give it a chance. Let's just do this sampler. We try 5 different ways. And lo and behold, they'll be like, wow, that actually wasn't so bad. I really like this option, but I still don't kind of like that option. So I think one thing it would be to be open-minded about different tools and why those tools would be helpful, and to open your mind to that. The survivor guilt is one of those things that when that pops up, I think you need to have a reframe in your head. There's a reason that your treatment, so you responded to your treatment. There's a role you have in whatever that is in regards to, your life role. So try to reframe that as quickly as possible. I think the longer we stay in a point that's negative, or we have that negative self-talk, the kind of worse that is. So we need to develop a toolbox, and our toolbox needs to have all these tools that we can pull out very quickly to help us in those situations. And I think that's vitally important as you think about mental health and think about the fact that we have limited resources. So how do you learn those tools? How do you use web-based tools? How do you use supportive care organizations? And then build your toolbox so that you can empower yourself with the skills that you need to address those whenever they pop up, or if it's more chronic, how you manage that both during and into extended survivorship.
Thank you. Okay, let's see. What is your recommended method of cancer surveillance after treatment for colorectal cancer?
So the recommended treatment is a loaded question. So there's lots of loaded questions. What I would recommend is that you take that question and ask your cancer care team. I would want your physician to give you, here's why we are doing this type of surveillance. Here's how often we do it. It includes both, maybe colonoscopy plus maybe one of those blood tests to look at minimal residual disease. You want to know, what are the tests, how often, and why am I doing them? It's going to differ. And I will tell you, it's interesting. As I mentioned, I work with a lot of primary care, and primary care will say, I would love to be more active in managing that my colon cancer survivors, but I don't know the frequency. How often do they want to do it? What kind, so your other physicians in your life will also ask the same question that you just asked. So I think it's a very important question to ask. It's very important for it to be documented in your notes that goes to those other physicians and that you have, so that you have that understanding. So I would empower you to very pointedly ask that question.
Great, thank you. The next one is, how do I know if I've had biomarker testing? Is
Yep.
it something a colorectal cancer survivor should have done?
So biomarker testing is something that early on, I guarantee that you had some biomarkers run. As we highlighted on the one little continuum slide, things like the RAS mutations or BRAF or HER2, a lot of those are done and you don't even know they're done. And so the only way that you may have known is that maybe the treatment that was discussed was based on that biomarker. So the other piece I always suggest to our patients is, and survivors, is that you do have your own sort of notebook where you keep that information. If you have access to your electronic health record through a portal or through your an app, you would be able to go on and look under laboratory tests, and you should see that. There's a variety of types of companies. And I will tell you, earlier today, I was looking at Biomarkers 101 on the Colorectal Cancer Alliance's website, and it actually shows you all the different names of the biomarkers and gives you some nice information about them. So if you want to refresh what those biomarkers are, I would look at that site, and then you're able to then match it up onto some of the laboratory reports that you would see. I would simply ask your healthcare provider, your oncologist, or your oncology nurse. I would just say, could you give me a copy of my biomarker report, or next generation testing report, or genetic or genomic testing report? The hard part about the names of these is the nomenclature is hard. There is a group that has, including Colorectal Cancer Alliance, who's really aligned on the terms. Biomarker is the accepted term, but it may be called different things in your medical record. So just ask that question, get a copy, or familiarize yourself with those so that you understand what was run and how it was run. Now, I will tell you, if you had germline testing where it looked to see if you were born with one of these mutations, you would have had to have signed a requisition agreeing to have that testing. So the somatic tests, those biomarkers that are in the tumor and that are done to help us inform the treatment or clinical trial decision making, that doesn't require a signature. But once it goes into this germline, or what you were born with, it does require your signature. So most patients remember more when they had to sign something than the ones that don't require that, because it was just run, and it's just part of the standard operating procedure for understanding the tumor. But double check, ask the question, and get a copy.
Thank you. The next question is, I am a CRC survivor. My kids are still young. How at risk are they of developing colorectal cancer themselves?
Right. I think there's multiple answers to that question too. The first is, as a person who has younger children, I assume you might be a little bit younger yourself. So germline testing, or knowing that family history, is something you want to explore. Was that done? Do you have a genetic mutation? Because if you have a genetic mutation, then, and that's the type you inherited from mom or dad, then each of your children would have an independent flip of the coin chance of having that same mutation. If you don't have a mutation, it doesn't mean that your kids don't have risk, but they don't have a genetic risk. So the hard part is, you want to look at your family history, you want to look at your age of onset, you want to look at what type of testing you had done, and that's going to influence not only when your kids would start screening, but also what level of risk they have, and should any other preventive interventions be recommended based on that level of risk. So that's where you want to once again ask your cancer care team, if you haven't talked to someone who has a genetic risk background, that could be a genetic counselor, a cancer risk counselor. It could be, a variety of people serve a role in cancer risk counseling, but you definitely want to explore that just so that you understand your risk and how it impacts them. And I will also tell you, which we did not dive into, is that with those germline mutations, or the kind that you would inherit from mom or dad, not just colon cancer is one of the cancer, the risks. You could also have a risk for endometrial and uterine cancer if you're female. You could have a risk for second colon cancers. So really important to know, what your level of risk is for yourself, for your kids, and to make sure that you're doing the right preventive and screening strategies along the way.
Would people go to genetic counselors for that, or go back to their doctor and talk more in depth about it?
That's a good question. And I know that in different practices, it looks different. We've had a lot of our nurse practitioners go through different training courses so that they can actually answer a lot of those questions in the clinic. A lot of our physicians answer those questions. A lot are going to refer directly to genetic counseling. So there's not one right answer, but there are some good resources out there. But I would always start with my cancer care team, because frankly, you may have actually had genetic testing and some patients just don't know they had it. It was such a busy time. There were so many tests being done. They don't remember that they had it. So it's always good to right size with your cancer care team and then go down a pathway that they would help you navigate.
Awesome. Great. Thank you. The next one is, it's awesome to see the ranks of cancer survivors are growing. To what do you attribute increased survivorship?
Yes, that's a really great question. It's a hopeful question. Number one, the first answer is we have a lot better screening tools than we ever had before. Now, I've worked in cancer prevention and survivorship, as I mentioned, for over 27 years now. Prevention is a lofty term, right? One of the hardest things is to prevent cancer. We screen and detect it hopefully early, or detect it, but prevention is a very hard term. So, and hard to achieve. So I think the first thing is we have much better screening tools. So we are finding things at earlier stages. And so patients are living longer because they have more favorable disease. The second piece of that is we have more targeted therapies that are specific, as we said, to the biomarker. They have less toxicity, and we're able to target who really needs treatment, who needs what type of treatment, how long do they need it. So that's much more specific. And patients are responding at higher rates. The other piece that has changed enormously, and immunotherapy has been a big piece of this, we have so many more patients living with their cancer. So if you would have looked at those numbers in the 70s, you didn't have a lot of patients living with their cancer. Now we have patients living for extended periods of time with relatively good quality of life. And that's another piece of the pie. But I think that screening, early detection, targeted therapy, and living longer with cancer are all really kind of positives in why we see this increase in cancer survivors.
Great. Thank you. It looks like the last question is for me. A bonus question is, can you tell me more about the Colorectal Cancer Alliance's patient navigation program and how to get access? Well, absolutely. You can go on our website. You can call the helpline, a 1-800 number, and directly speak to a patient navigator. You could also do a chat we have on the webpage itself and talk directly to a navigator. And looks like one more question. Let me see.
These are great questions, by the way. So thank you to the troops out there. We appreciate it. Yes.
Okay, so then the last question is when or do recurrence chances diminish after chemo and radiation?
Well, you guys are asking loaded questions, though. So this one, I feel like there was a kind of a phrase that people would say is like, once you get to 5 years, you're good to go. I mean, how many times have you heard this? Patients will still come in and say this, and I quickly reframe that, because we are always at risk for cancer, right? So let's just start with that. All of us are always at risk. Once we have a diagnosis, we are at risk for that cancer coming back, for a new cancer. So how do we put that into perspective and understand, if we have a diagnosis, how does the treatment that we went through reduce that risk for that cancer coming back? And in some cases, maybe we're giving maintenance therapy that also kind of addresses both reoccurrence and hopefully prevention. So I think that the important part, and this is something where my partners always know when I've talked to a patient, because the patients will ask for something called absolute benefit. So we use lots of statistics, and you're like, what? Just give me, like, take it into like how I can understand it in practical terms. And what I mean by practical terms is that we have relative risk and an absolute risk. So when you hear that a therapy reduces the risk of recurrence by 50%, you're like, wow, that's gangbusters. That's huge. But you also need to know, what is the actual chance of that reoccurrence. So if your chance of recurrence is 3% and we reduce it by 50%, or if your chance of recurrence is 25% and you reduce it by 12.5%, those are very different numbers. So you need to understand the true risk of recurrence or new primary. You need to understand the impact of the treatment. And why that's important is because if there is a very low absolute benefit, you as a patient may say, wow, there's a whole lot of side effects. I have 4 comorbid conditions. Is this cost benefit actually worth it? So your provider is going to give you the best case scenario, but there's ways to drill down to understand your absolute benefit, the risk of recurrence, how this will impact that. And those are the questions that are the hard questions, because we don't have, once again, a black and white answer. There's a lot of gray. And the hard part is you don't like gray and we don't like gray. So nobody likes to talk in the gray, but we live in the gray. So how do we help set up the expectation about recurrence, about benefit? And I think really understanding the limitations of the tools we have, how you potentially will respond, but we can't predict that with any 100% accuracy. And then what are the tools we're going to use? So if it does come back, we're kind of on that and you have a next step. I think those are the hard part, because it's constantly in the back of your mind. What should I be looking for? If I have some bloating, if I have normal symptoms that would happen as part of us living our lives, it's very common for patients to overinterpret those for a long time. So how do we put that into perspective that we're still going to have, normal sorts of things happen to us, but when do we stop associating everything with cancer? And for some people, I don't know if they ever do, but it's really important to put that into context, because there is an intensity to that. How long should that symptom be there before I call my doctor? What was potentially a stimulus that caused that? Was I on a cruise for 10 days and now I have some GI symptoms? You got to put stuff in context, and those are important things to sort of come to grips with yourself and realize, you don't want to be like the person who calls the doctor all the time, but you need to put that into the thought process. But I know that was a long answer, but I think it's important to know that numbers are tricky. You need to know expectations, and you just need to be part of that conversation.
Thank you. Thank you.
You bet.
I think that's all the time we have today. And I thank you so much, Dr. Klemp, for spending time with us on this important topic. It was amazing. I want the viewers to know that they can watch this video later, and you'll just be able to find it on bluehq.org, the Alliance's online patient support hub. And then just thank you everyone for attending, and please stick around to answer the post-talk survey. Your participation is really important because we do this for you, and we want to make sure that we do focus on the things that you guys need. And so I just want to say have a great day, and thank you so much, everyone.
Bye. Thank you.